So, Shilpa madam, we are simultaneously live as well. And I think now you can start it.
Yeah. So I welcome all of you to this session. We have almost 292 people who are with us today. So thank you, Kiran sir, for this initiative. And let me just start with introducing the speaker today. Dr. Mehta sir is an all-round OBGYN infertility specialist, urogynec, gyne-onco, and a lab surgeon par excellence who has achieved all this in a short span of 8 years in private practice at Sri IVF Clinic, Mumbai. Is an entrepreneur who has Meta-verified Facebook surgical group, Project Pelvis, which has a huge 18,800 gynecs all across the world. He's an YouTuber and an academician with a 330,000 followers on YouTube. He has been an influencer to many young gynecologists by his popular Facebook live surgeries and a role model to many, including me, with his honesty, humility, hard work, and dedication. It's my privilege to moderate this session, courtesy Dr. Kiran sir, with a topic so relevant, but which is not discussed enough. So we will start the session, Dr. Jay sir. Yeah, you can take over.
Okay, so I guess I hope everybody is able to listen because our streaming is gone live. And from what we see on our streaming, I think it is absolutely clear and audible to everyone. So, so basically what is important is that most of you, unless you are connected on your own or unless you have connected to internet audio, there is no way in which you are going to be able to listen. So kindly see that it is done for you, because otherwise you will just see our faces. Okay. And this is a very, very important topic, as Dr. Shilpa has already mentioned. And I think it is a great initiative, this Monday initiative, which is taken by Dr. Kiran Kurpoti sir. I think it is a great initiative by him, because that is something which is, popularizing these type of topics which are not very commonly discussed, and we are able to discuss these topics at length. So thank you so much, Kiran sir. Really good. I mean, I think it's a great thing, right? So actually, this topic is something which is very close to my heart, because it is something related to stress incontinence. And today we are going to be discussing almost everything that people need to understand, know about stress urine incontinence when you are treating it with Colposuspension. That means with Burch Colposuspension, right? So it is very important for us to understand one thing, that this is a very common problem. That is the first thing which we should understand. There is no second thought about it. Urine incontinence, be it urge incontinence or stress incontinence, is a really common problem, right? Second, it's very simple to differentiate overactive bladder as compared to stress incontinence. Okay, overactive bladder has a tendency to pass urine only on having the urge to pass urine. That is the most important thing. Stress incontinence is where you pass urine without any urge. Okay, it is a leak of urine. There is no urge in stress incontinence. If it is a genuine stress incontinence, the patient has no urge. Whatever little capacity of the bladder is to get full, the bladder gets full on its own sweet time. And due to whatever type of activity one performs, there is incontinence. Okay. It's also very, very important to understand that when you are looking at stress incontinence in our country, in India, okay, some of the commonest causes which are missed out are infections. Urine tract infections, if you just do a urine culture on 50% of these patients, and if you treat them nicely with antibiotics, then believe me, that small urge and that small stress, both types of incontinence, okay, will actually disappear with this course of antibiotics should the patient be actually having any form of urine infections. All right. Now, apart from all this which we have mentioned, it is absolutely important that when you are looking at stress incontinence, the most important thing the gynecologist should know is that it is a diagnosis which you can make on clinical examination. Okay. For stress incontinence, you do not need to emphasize blindly that, okay, I need urodynamic study. Believe me, if you have ever seen a urodynamic study, That is the last test which you will recommend to your patient. Okay, it is so uncomfortable to do a urodynamic study. It is so uncomfortable to have micturition under observation. Okay, it is something where you are trying to stimulate physiology in a urodynamic study, but it is so non-physiological. It is such a non-physiological test. Obviously, it has its advantages. I am not here to tell you that no, you should not do it. Definitely, there is an indication to do urodynamic studies when you are having a confusion between some types of overactive bladder, if it is purely overactive, if it is hyperactivity of the detrusor. Though you can identify all this clinically as well, it's good for confirmation sakes. Okay, but in stress incontinence, what we are trying to talk right now is stress incontinence. And when we try to talk of stress incontinence, for heaven's sake, remember this thing, that you need not lay a lot of importance to doing a urodynamic examination for these patients. Okay. With this, I would just like to take some permission to do some drawings. Okay. I'm not going to show you any video today. As usual, we have planned that we are not going to demonstrate these videos. The reason why we are not going to demonstrate these videos is because we are doing these surgeries live on Facebook. Around close to 370, 380 people who have joined in. All of you can go through Facebook, watch this surgery live. It is a simple surgery once you know how to do it. But I think what is even more important in stress incontinence is to understand the physiology and the pathology and anatomy. As a result of which, if you understand all these things nicely, if you understand the concept of treating stress incontinence, then no matter what technique you apply, you can say that, no, I prefer TVT over TOT. Okay, I am a strong proponent of TVT. Somebody else can say, no, I am a strong proponent of TOT over TVT. Okay, and you can have a third person who is going to come and tell you that, no, I don't like both of them. Both of them involve putting a tape inside, and I am very, very comfortable in this situation by doing a Burch. You can have all these three things. Okay, simultaneously, please understand, in all these situations, very, very important, there are certain countries where use of tape is completely banned. Okay, there are certain countries where you cannot put a tape for incontinence. Okay, so it depends on what category of patients you are treating and what type of consents you are taking. We end up doing a lot of urine incontinence work, and we normally give the choice to an Indian patient that, do you want to do a TOT or do you want to put a Burch? Okay, but before we come to all these things, I would just like to probably share something which is on a whiteboard. So I think my whiteboard is visible. Kiran sir, Shilpa madam, is it visible?
Yes, yes. Visible.
Okay. What is very important for all of us to understand is actually this anatomy. See this. When you are looking at the female bladder, your female bladder is going to be something like this. Okay. Inside this, you have the muscle, transitional epithelium, and the detrusor muscle. All right. Now, when you actually try and understand the vagina, so I will draw the vagina in a different color. Let's say I'm drawing it in yellow color. The vagina is behind here. It is here. Okay. And I will also draw it in the opposite plane so that everybody understands it very beautifully. This diagram, if you understand, the lecture should actually finish, because that marks the end of everything. Sir, can the whiteboard be seen? Because we have an issue.
It can be seen. It can be seen.
It can be seen. Fantastic. Okay. So see, this is very, very important. So I will just label for everyone. Okay. I'll just label everything. See, this is the vagina. We all know this. This is the bladder. Yeah. And this is the urethra. Same here. This is the bladder. Okay. These two people are vagina. Okay. Once we have identified the vagina, only thing which is left to identify for all of us is then just the bladder. Okay. So fine. Here we go. And this is your urethra. Okay. So what is important for us to understand? See, you have something called as a sphincter here, which is present here. Here. Correct? This is your sphincter. Simple diagram, okay? No rocket science which is involved in this. At the level of the mid-urethra, okay, you have a tissue which is present, which is the fascia. So I will just draw the fascia here. I'll draw the fascia here. So here, this fascia is actually here. Underneath the sphincter also, below also. I'll draw it with dotted lines so that you understand that the fascia is present underneath this entire region. Okay, all this is fascia. Okay, what is important to understand is that in order to maintain a good physiology, God has also gifted one more organ here. This is not an organ, this is actually a bone. This is the pubic bone. Okay, so whenever somebody has a sensation to pass urine, okay, and if in case that situation is not an appropriate situation, okay, if in case we think that nahi baba, this situation is not an accurate or an appropriate situation, what happens to this? You know, our natural instinct, okay, or God's natural instinct or body's natural instinct, let's just put it this way, is to ensure that the entire endopelvic fascia pushes the vagina up through this fascia. Okay, so this allows the distance between the urethra and the pubic symphysis to go down. Simultaneously, this sphincter also contracts a little. Okay, this sphincter also contracts a little, but mainly it is this pull. Understanding? Now, normally the pressure of this pull is far more than an external stress over the bladder. That means your activity like coughing, jumping, dancing, running, hopping, skipping, all these activities, no, the pressure which they exert over the bladder is very, very less compared to this pressure. As a result of which, you have this thing, which is called, you have continence. Very, very simple, right? Nothing beats this explanation. Okay. If in case you were to look at it in 3D, actually the 3D orientation is such that it, you know, actually fits inside like a hammock. This hammock is most prominent of the fascia at the level of the mid-urethra. And because this is most prominent at the level of the mid-urethra, this is a very, very simple explanation. Because it is most prominent at mid-urethra, all your surgeries are involved in strengthening this fascia at the level of the mid-urethra only. Okay, so when you put a tape, you are putting a mid-urethral sling. When you do a Burch, you are taking one anchor through the mid-urethra. When you put a TVT, it is a mid-urethral anchor which goes. When you put a TOT, it is a mid-urethral anchor which goes. If you understand the female pelvis is actually tilted. So how is the female pelvis tilted? See, pubic symphysis is here, sacral promontory is somewhere behind, and this is how it is. See this is how the bladder is in the pelvis, this is how the vagina is, and then there is a uterus on top of it. So all this fascia which is present is actually pushing the vagina towards the pubic symphysis. It's a very simple logic, and this is the logic of your entire treatment. Okay, so try and understand. You can have two problems when you are trying to understand any form of stress incontinence. Okay, one problem could be you are having internal sphincter deficiency. Okay, that means there is some problem in the internal sphincter. This problem in the internal sphincter is more than 80% of the times, either iatrogenic or traumatic. Okay, I don't want to exaggerate more on the iatrogenic aspect or the traumatic aspect, but I want us to remember that it is due to this. All right. And the second, which is even much more common, is something called as, which we commonly address in our conference. It is urethral hypermobility. What does that mean? This urethra is not very stable. at this juncture. Because the urethra is not very stable at the juncture, it skips this region of the pubic symphysis. So sometimes the urethra goes in this direction, sometimes the urethra goes in this direction. None of these directional changes cause a good compression. Because these directional changes don't cause a good compression, urethral hypermobility is usually a progressive stress incontinence. Okay, over the years, it starts from one drop. When the entire world, okay, the whole world, including doctors, everybody is going to tell the patient, do not do surgery. You should do Kegel's exercise only. Okay, I have seen people who have a frank leak. They are throwing out 1 liter of urine every time they cough. Okay, but still you are recommending Kegel's exercise. So I want to give some importance to this wonderful thing called Kegel's exercise. When I just rub everything off, I'll show you what is Kegel's exercise. Please remember one thing, a gynecologist can be trained in giving training in Kegel exercise, but Kegel exercise is actually given by a physiotherapist. Okay. Second, a Kegel exercise is not just Kegel exercise. A Kegel exercise, if you ask a good physiotherapist, he's going to tell you that in Kegel exercise, they also do that, ultrasound, radiation over the muscle to make it straight. They give constant stimulation to that pelvic muscle, okay, in order to make it tight. So what is Kegel's exercise? What is it that you are trying to strengthen in the Kegel's exercise? Okay, see this. You have this, levator ani muscle, correct? People say that when you do Kegel's exercise, you are supposed to squeeze the levator ani muscle. Okay, that is what you are trying to do. You're trying to hold for approximately 10 to 12 seconds. You are supposed to do around 10 to 15 such repetitions, and that is supposed to happen approximately 4 to 5 times in a day, which is supposed to happen at least for more than 3 months. Okay, you can't do this one time and say Kegel exercise is the best thing on earth. Okay, you can't really do this. If you do this, and if you actually genuinely go and ask a physiotherapist, he will tell you that Kegel exercise will work only when there is a drop leak. Okay, only if the patient is having this sensation of something called as wetness. If the patient is having a sensation of wetness, that is when the Kegel exercise will work the best. Okay, but remember one thing, Kegel exercise does not really offer any permanent solution. Kegel exercise is also a diminishing role as the disease keeps on progressing, and this disease will keep on progressing the minute a lady is established into something called as estrogen deficiency. The more estrogen goes down, the collagen in between this muscle, no matter how much Kegel you do, if you do Kegel from morning to evening to night, no matter how much you do, in entire situation like this, what is going to happen is that despite doing your Kegel, because estrogen has gone down drastically, okay, the collagen becomes weak, and then over a period of time, this drop leak gets converted into something called as a frank leak. And when you have a frank leak, all these Kegel, all these things just stop working. Okay, that is important. So please keep that in mind. Do not take Kegel's therapy as the only line of management. Okay, that is not how you are supposed to treat any form of incontinence. At this point in time, before I actually draw the diagram for the surgery, I want to address a very, very important issue. There is a huge popularism in our country. It's actually nonsense, but it is popularism. Okay, in our country, where somebody is trying to promote, lasers, okay, in incontinence, right? There is also somebody who is desperately trying to promote Tesla chairs, okay, for incontinence. Okay, I do not want to name these people. In fact, they don't even have any sponsorship from the company whom they are trying to promote. Okay, just to give a huge shocker to these people by mistake if they are listening. Unfortunately, I happen to be one of those guys who is involved in importing some of these lasers in India. Okay, so kindly do not try and teach at least me about these lasers. Okay, what is important to understand is this: these lasers have this, they have some role in vaginal tightening, they have a role in tightening of collagen. Okay, they are fractional CO2 lasers. Okay, so don't get confused by all these things. I'll take a session on all these things very soon, how to understand lasers in cosmetic gynecology. And believe me, after you listen to my session, all of you will take a refund from these laser companies. Okay, so when you take a fractional CO2 laser, collagen is going to become active only and only when estrogen is present. If the estrogen is absent, okay, then in that situation, your laser, even if it's like dynogest in endometriosis, okay, even if you inject the laser, keep the laser inside the bladder in the fascia, it will not act in a situation where estrogen levels have gone down. Kindly understand, the entire mechanism of giving laser is dependent on collagen. It is not dependent on me. It is not dependent on you. Okay, God has blessed you with the world's best hands. Okay, but laser is a machine. Laser only understands collagen. Laser does not understand anything else. Okay, so for heaven's sake, okay, no matter how much you like lasers, and even if you are invested into it, there are certain investments in life which can be written off as bad investments, and laser at this point in time should be considered as a not so great investment for curing. It is not to cure incontinence. Okay, it will give you collagen tightening, it will give you vaginal tightening. Once collagen tightening and vaginal tightening occurs, you need multiple settings and it is not permanent. Okay, so after that drop leak stage where you may choose to use laser, where somebody comes and tells you that, I have had one episode when I coughed 950 times, one drop of urine came out. Okay, that is the ideal indication to do laser. Ideal indication. Okay, nobody knows. Patient also doesn't know if she is leaking. Doctor also doesn't know if she is leaking. Laser also does not know if she is leaking. When all three people are equally blinded, that is when the laser will work the best. Understanding? If your examination findings tell you that there is a leak, if you can see, if your eyes are open and if you can see that the patient is leaking, Kegel exercise will not work. Lasers will not work. Please remember this. This is a very important take-home point. I am again repeating to all the people who love buying lasers, thank you, because you are contributing a part to my income as well when you buy these lasers. But at this point in time, in gynecology, I think you should take it with a strong word of caution. Okay, very strong word of caution. Before we move on to some other things I want to address, there are people who are really fancying things like putting PRP injections in the urethra. There are people who they have never attempted all this. Huh? Let me tell this also to you. They have never attempted, they have never seen, but they love talking about it. They have case series of 2 cases, okay, where they thought that they put PRP inside the urethra. It's so comedy when you listen to such type of things, no? What is the role of PRP? Let me please make, fortunately, by mistake, people who went to Europe, and if at all they were in the audience actually attending ESHRE, then they would have realized that now it has been proven that PRP in ovarian rejuvenation has no role. Okay, simultaneously, PRP has no role in strengthening the internal sphincter as well. Okay, at max, what may work is something called as a bulking agent. Okay, what is this bulking agent? This bulking agent is actually injected under the urethra. Where is it injected? Mid urethra. Okay, nothing is going to be injected above the mid urethra. Why do you inject a bulking agent in the mid urethra? So that you can cause a kink. Okay, you can cause a kink. The minute you cause a kink, you are causing one very, very important problem. which people don't understand because they've never used a bulking agent. You are actually not curing stress incontinence, but you are increasing the pressure inside the bladder. Every time the patient even wants to pass normal urine, no, they have to apply slightly more amount of contractility from the detrusor to pass that urine. And as a result of this, if you have not used your bulking agents correctly, people who have genuinely used it are going to give you an honest feedback that they will see patients having more recurrent urinary tract infections, especially in elderly women after using bulking agents. So I personally, again, I'm not very strongly in favor of using any form of bulking agents. 3 bulking agents are commonly available in India. You can Google them and you can order them. They are not that expensive. They are very easy to inject. Okay, there are some people whom I know, somebody had called me up, they injected the bulking agent in the vagina and they thought that the vaginal muscle has become edematous. No problem. Even that is going to work, because even if the vagina becomes edematous, okay, the urethra will still kink, because the distance between the urethra and vagina is in a few millimeters. The fascia is actually a few millimeters. The horizontal width of the tape which is used, okay, is actually less than 2 millimeters. So you can imagine how thin that fascia is out there. Okay. I'm actually surprised that for a lecture like this, we have around 500 people who are listening for 30 minutes, Moving on. Okay. Is there anything which Shilpa madam and Kiran sir want me to address before I go on to drawing the diagrams of surgery? Because I'm not going to show the live surgery that can be seen on Facebook.
Can you tell which are the bulking agents for the benefit of the audience? And and role of Botox.
Botox. Okay, so I'll address Botox first, because Botox is something which is very common. No role of Botox in stress incontinence. Okay, no role of Botox in stress incontinence. No role, limited role of Botox plus photocoagulation in proven interstitial cystitis. Okay, for overactive bladder, where it may benefit approximately 60 to 70% patients. But the problem with Botox is people are going to need these injections every 12-13 months. Some people need them every 9 months. There is just one important thing which I want to mention about Botox. When you are trying to understand Botox, do not use so much of Botox in patients who are already having urge incontinence due to a systemic pathology. For example, if somebody is having urge incontinence due to diabetes, understanding heavy urge incontinence, heavy overactive bladder due to diabetic pathology, Botox really does not really work nicely. Okay, does not really work very nicely. So just keep that in mind. Bulking agents, sir, I'll post it on our WhatsApp groups with photos. I think we have one bulking agent in our hospital as well. It is supplied to, it is commonly supplied in the hospital. I'll click a photo and I'll post it tomorrow. But I don't recommend it. As I said, maybe we use a bulking agent for just, 1 or 2 stupid patients in a year, and definitely not more than that.
Yeah, we'll go ahead with the surgical diagrams.
Okay, fine. So again, I will go on to the whiteboard and maybe Shilpa madam or Kiran sir can tell me if the whiteboard is visible.
Yeah, the whiteboard is visible.
Yeah.
Later on, you can touch base upon the anatomy if at all it is feasible. The one which you explained us during your live surgery.
Absolutely, sir. I'm just about to do that now.
Yeah.
Okay. See, first I will draw the laparoscopic picture. Okay. In the laparoscopic picture, you have the vagina like this. Okay. Now, over this vagina, this is what exactly we are going to see. You will see a urethra. You will see a Foley's bulb. Okay. This is what you will normally see. When you are operating Burch, this is what you will normally see. Okay. And you, of course, have the bladder. Huh? So I'm just drawing the bladder also. But the bladder is going to be up, no? So the bladder is a huge organ. It's going to be way above the vagina also. Okay. So I'm drawing that also for everyone. Okay. This anatomy picture, if you register in your head, no, you will never have to attend any live surgery for doing any urine incontinence repair. See, this is how your bladder is. Correct? Here in front, in the front, you have pubic symphysis, which you see like this. Okay, you will see this. Then you have pectineal bones. Pectineal bone pay. Okay, you have Cooper's ligament. Here, see, like this. Like this. Exactly like this. Huh? This is exactly like this, what you have. And underneath these people, okay, underneath them, here, you have the muscle here. This is the obturator muscle, which is then joining into becoming the levator muscle. So you will see both those parts here, underneath. Okay.
Yeah.
Now, this is your picture. This is your picture which you see in doing Burch. Now you can do this Burch open, laparoscopic, whatever you like, you do, but you do. Understanding? Best, if you want to learn anatomy, is to use 3D. If you don't want to use 3D, it is still okay. Right? Now, what your assistant does in this surgery is the most important thing, honestly. See, you are supposed to preserve. There is going to be fascia which is present here. All this, if you ever see my surgery, or anybody who is operating nicely, if you ever see their surgeries, you will see this fascia lying down like this. That yellow color, I'm drawing it yellow because it is yellow. Understanding, this fascia is going to appear yellow in color. You are never going to see a proper urethra. In fact, your urethra, what you see in the laparoscope, is your urethra which you feel through the vagina. This is the urethra which you feel through the vagina. Remember, this is just a 4 centimeter part in a lady. Okay, it is a very small part. Very, very, very small part. Yeah, okay, Rachna, this is just for you. Okay, I am labeling all this just for you. So this is the bladder. Okay, this is the vagina. This is your Foley's bulb. This is pubic symphysis. This is urethra. This is pectineal. This is muscle. And this is the fascia. Okay, I hope the label diagram is now complete and sort of beautifully visible to people. Right? What your assistant is supposed to do? It's very, very simple. If I draw the vagina here like this, okay, you have this dissected urethra which is lying down above with the Foley's bulb. Okay, so you have the urethra with the Foley's bulb lying down above. So you are supposed to put a dilator, or what I prefer is a gloved finger, gloved index finger. I'll draw finger also. It looks like a finger at least. Okay, so this is the finger. So I prefer this. Now I know people are going to say, no, never do this. You should use finger with rubber tape. Okay, so that your needle does not pass through the finger. You should use this thing, you should use a dilator. Okay, so that assistant does not get injured, all these things. Yes, absolutely, you are right. Okay, but when you really want to individualize, see guys, please try and understand. I operate on people who have failed these surgeries. Okay, people who have done TOT after having struggling for 2-3 years. People who have done TVT after struggling for 2-3 years, and when that surgery fails, that is when they predominantly come to us and we do a Burch in them. So our problem is to do a very accurate surgery. That is our issue. Understanding? And when we want to do an accurate surgery, I put my finger. Okay, because I am happy with that. So what does my finger do? I will just label these points, and I think you will never forget these points from here on. Okay, see this. I will draw these points now. This is your mid urethra, point 1. Same you are supposed to take on mid urethra, point 2. Bladder neck, point 3. Bladder neck on opposite side, point 4. Okay, very simple. Just remember these 4 points. Anchor number 1, anchor number 2, anchor number 3, anchor number 4. The suture material which I like is Prolene because it is monofilament and it does not cause any reactions. Okay, and I will go just below this. So my anchor will go here like this, just below this. Okay, just below this. You will never see my anchor at the level of the bone. You will never see my anchor at the level of the bone. Believe me, people who are taking anchors at the level of the bone are yet to have patient in whom the patient is having a retention post-surgery and patient is not able to pass urine. The reason is when you take an anchor through the bone, what typically happens is this vagina gets really, really pulled up. When the vagina gets pulled up, there is no dynamic adjustment which the body can do. Look, people are walking in a day. People are sitting in a day. What happens in Indian toilets? Come on, let's try and understand. Nowadays, 99, at least the patients whom I treat, 99% of the patients are using Western commodes. Okay. So whenever they are using Western commodes, they are not completely squatting. They are just half squatting. Understanding? In that half squatting, they need that dynamic adjustment for the body to occur so that that urine passes out at that time. That time urine, you are not worried about urine leaking. When she is sitting on the commode, urine should leak. Understanding? So that she can pass urine. The exact reverse should happen to our patient when she's standing. When she's walking. Look, I end up doing surgeries on women who are acting in movies, who are jumping, who are dancing, who are dancers themselves, okay, who are professional dancers having urine incontinence, who are professional athletes having urine incontinence. Okay, so you must keep in mind that your anchor is a very, very dynamic anchor. The minute you keep a dynamic anchor, which is slightly loose, slightly tight, what typically happens is that little fascia adjustment will happen on its own, okay, because of the reversed anatomy. And once the fascia gets adjusted on its own, patient is super, super, super happy. Okay. Commonly, when we try to address this same issue, okay, when we try to address this exact same issue, when we are trying to do a TOT, we are doing something different in a TOT. Okay, I will just draw a TOT and show it to you guys. I love TOT. Okay, so I'll just clear off everything and I'll show what we do in a TOT. Okay, what do we do? See, you have your urethral meatus here. Correct? Underneath the urethral meatus, you have the vagina. Correct? When you go by the side of this, you have in 3D something which you see here, which is called as a ramus. So you feel this ramus. Correct? The patient is in this position. So her legs are up. Na? The patient's legs are up. Na? She is in lithotomy position. Correct? Na? When you are doing this surgery. So her legs are something like that. At this point, there is one beautiful muscle which comes and gets inserted outside, which is called as adductor muscles. Here. Why I'm showing this is because this is important. Okay, here, adductor muscle is here. Okay, see. So what you are trying to do through this, there is inside one more muscle which is called as obturator internus muscle. Here, obturator internus muscle is here, and you have the vascular supply up here. That obturator nerve artery vein, remember VAN, jo apan bolte hai, it exits here. It exits through the obturator canal here and it goes inside the adductor magnus, adductor longus, adductor medius, whatever muscle you want to call. It goes inside those muscles and it supplies. So see what you are doing in all this. You are cutting this open. Ye tumne anterior vagina ko cut kar diya. Local anesthesia, whatever anesthesia you want to give. I prefer to do it under spinal. I prefer to do it under general based on patient's condition, but spinal is our standard. Okay. And you are putting a tape which comes out here. So that tape is actually going mid-urethral and is coming out here. Okay. This is your mid-urethral tape. So what it does to your patient is automatically, if you look at it in sagittal section, see, very simple. That is your bladder. That is the vagina. Your mid-urethral tape in your sagittal section is somewhere here. So it causes fibrosis here. See, whenever it causes fibrosis here, automatically the hammock action, provided it is purely urethral hypermobility, the hammock action gets corrected. Understanding? This will not work when you have internal sphincter deficiency. Because in internal sphincter deficiency, you need to go high up, you need to address the bladder neck also. So when you have internal sphincter deficiency, your treatment of choice is to do Burch. Very simple. Okay. But keep in mind, for routine TOT, this is what we do. As a result of which, you will have some patients who are complaining of thigh pain. Understanding? Somebody had asked this question on the group. So it is very simple. When you have thigh pain for the first one day, put your finger here, and massage this ramus. That thigh pain is not because of the tape. That thigh pain is happening due to periosteitis here. Okay, that thigh pain is related to the periosteitis of the ramus. So the minute you massage the ramus, okay, automatically in 2-3 days, the thigh pain will go away. Patient will be super duper happy. Okay, but this is your basic understanding of doing the TOT repair. Absolutely basic understanding. As a result of which, no, you ask the patient to hyperflex and abduct in that surgery. Sometimes you will see people speaking this word, hyperflex and abduct. Why they do that? So that this anchor goes up and this canal goes even higher, so that there is no vascular injury which happens, there is no nerve injury which happens due to the mesh. Okay, that is why you are supposed to do hyperflexion and abduction if at all you are doing it, or if at all somebody is still following the technique. Honestly speaking, on an average, if I am doing, let's say, 200 SUI repairs in a year, I think I must be doing more, but let's say if I am doing 200, what is going to happen is approximately 120 will be Burch, 80 will be TOT. This 80 are 100% Indian patients only. Okay, out of this 120, you will have maybe, let's say, around 75 to 80 who are Indian. You will have around 65, 70 patients who are non-Indian residents. Okay, because these guys are very particular about not using the mesh. Okay, and you have to still treat them. You can't really tell them that nahi, mesh to bhai main use karunga, wo mera sort of janma siddha adhikar hai. There is nothing like that. Okay, I hope with so much surgical drawings, now when you register this and go and see the live surgery, you will understand why my fingers were adjusting continuously though for that 1 minute, where I want to take the anchor, where I want to take the other anchor, where I want to take the third, where I want to take the fourth. The minute you realize this concept, believe me, it's such a simple procedure. You kindly do not try to standardize your anchors, because every patient is different. You may use the same anchors in every patient won't get the same benefit. But if you use slightly different positioning of anchors in every patient, then almost every patient will get a good benefit. And I think that is a very, very important take-home point if somebody is attempting a lot of laparoscopic Burch repair. So I think now I am open to questions. Any questions is okay. From Shilpa madam and...
Yes. Jay, my first question is, clinically, how do you identify which patient has got a hypermobility of the urethra and which patient would require a TOT, vis-a-vis which patient has a bladder neck issue and would require a Burch clinically?
Yeah. See, there is something which is recommended as the Qtip test. Okay. Honestly, it's if you study it, then probably you will say that you jhoot bol raha hai. But I'll give you a very simple answer to do this. Okay. You know, you should take an earbud, commonly available in all our hospitals. No, just put lignocaine jelly over the earbud. Okay, and just put it in the urethra. This earbud is around 7 centimeters, 8 centimeters in length. Urethra is 4 centimeters. You will feel it has gone through the urethra. It's beautiful. It's completely anesthetized. Patient does not feel anything. Okay, and then you ask her to cough, or just ask her to strain. She's in supine position. Understanding? You will see that this earbud.
Okay.
This happens. Understanding? Now, normally when this happens, now this is just a rough test. Okay. Normally when this happens, this is usually hypermobility of the urethra. Okay. In internal sphincter deficiency, all this doesn't happen because the urethra is lying correctly. The sphincter is completely gone. Okay. In that situation. So you will not have that commonly seen. And in ISD, you can easily diagnose it that, okay, there is no movement of that. And you know, you are going to be doing something right.
Yes.
So, any role of duloxetine in SUI? One of
It is good. It is good for this wetness patients, you know, patients who are having a very, very mild leak. It is good for them. It is good for them. And it may work. It doesn't work in all. It may work in some.
Okay, and you don't do intermittent filling of the bladder when you are doing the surgery. You usually keep it.
No, I don't do it.
Okay, and how long do you keep the catheter for after the surgery?
4 hours.
4 hours.
Yeah. So what is important is this. See, you raised your eyebrow, no? Why you do it only for 4 hours? You know, you should keep it for 22 days. No, it is not like that. Please understand. A patient who has come to you with leaking, right? You need to ensure within that first 3 to 4 to 5 hours if she is free of leak or not. Okay. The best way to ensure that is remove her catheter. Okay, ask her to cough. If she's incontinent, she's incontinent, right? Even if she coughs, any which was post anesthesia, they may cough. Okay, then some urine should leak out if your surgery is not done correctly. This is one of your best tests, because see, a lot of times people think, no, this is incorrect. I have seen in my vast experience that after 6 weeks after you put a tape, there is more fibrosis. So when you put a tape, you should ensure that there is a dilator which is going and the tape is not tight. That is correct. But you need not do any of it. Once you look at the urethra, you will understand if the tape is snugly fit over it or if the tape is loosely fit over it. It is just going to come to you by looking. You need not put an artery, open, dilate. I have had people whom I've treated where they've put it, but the dilator, they've put it so beautifully that dilator has gone through the bladder neck. Understanding? And then it has caused a fistula. Okay, so repairing that fistula in a mesh is a very problematic thing. Better not to do all these things. I strongly do not recommend. It's a huge fad, I like to do cystoscopy in all patients. It's a huge, stupid thing to do cystoscopy for stress incontinence. You are treating the fascia. You are not treating the muscle or the transitional epithelium. You should do cystoscopy if you are worried that you've caused an injury. If your tape has gone through the bladder, guys, if your tape has gone through the bladder, believe me, okay, you don't need a cystoscopy. You don't need a cystoscopy. You will see it. It is in the bladder. Okay. And that is the lag gayi. If your tape has gone there only through the bladder, no, you have to do a proper reconstruction for the bladder. You can't just take one random stitch and come out. It is the whole tract is going to get necrosed. Okay, if that tape is there. We have removed these tapes. We have showed it live on Facebook on how to remove these tapes which have gone through the bladder. Okay, and it's a very, very tough thing to do. It is like fistula repair,
Okay. And do you do pre-op antibiotic coverage for these patients before operating? Not required?
If the culture is stating something, then yes. But it is better to do a culture, madam, for documentation.
Yeah.
Jay, Dr. Shriram Iyer is there. He's a very...
Oh, hi, guys. Shriram is somebody who is absolutely phenomenal in urogynecology. Okay. He is absolutely phenomenal. Yeah, Shriram bhai, what happened? Tell me.
So his question is there any specific indication physics where TOT will not work and only Burch would be the possibility?
In ISD, when you have internal sphincter deficiency, TOT will not work because your internal sphincter is still deficient. Okay. Because if that internal sphincter is still deficient, patient will still have leak no matter what you do in internal sphincter. Yeah, thanks, Shriram bhai.
Yeah, so the other question was, how do you differentiate? The one test that you told was the...
Is a Qtip.
Is a Qtip test. Okay.
Otherwise, you can do a urodynamic study, sir. They will give you an idea if the internal sphincter is deficient because the holding pressure will not be present.
Okay. Yeah. One question was, what is the role of urodynamic study?
I think we answered that. In genuine stress incontinence, apart from documentation purposes, no role.
Another question is, which is better, TVT or TVTO?
None.
Pardon? Sorry?
None. There is nothing called TVT is better than TOT. There are indications for doing that. I think there is also a lot of comfort which is involved in all these things. See, don't just go by indications. There are so many people who are so comfortable doing TVT. There are so many people who are so comfortable doing TOT. Okay. This, I think, okay, though there are people who will say that, no, for this 0.01% of the patient, I am a strong believer of doing TVT. Good, very good. We are proud of you. Okay. But what is important for people to understand is TVT will allow you to place your mesh slightly higher. Okay, because you are going through the abdomen. All right. TOT will be mid-urethral. TVT will be slightly higher. So if you want to break an argument, maybe TVT will help you when there is slightly more ISD, internal sphincter deficiency, as compared to hypermobility. Okay. But I want to give a very important point here. do not get carried away with TVT or TOT. In both these surgeries or in any surgery for incontinence, it is not that. It is your dissection which is your game changer. Please remember that. Even in TOT, dissection is safety. Even in TVT, dissection is safety. Even in Burch, it is your dissection which causes a lot of safety.
So among these three, coming to your choice of surgery, which one would you prefer? Burch or TVT, TOT?
See, as I said, I get a lot of patients for Burch. And now if you ask me, I am very happy with Burch. You know why? Because I'm able to individualize the Burch. I'm able to give them a pinpoint accuracy by doing Burch for them. Ultimately, what matters for the patient is that outcome. How good are they post surgery or post Burch? And I think results for Burch are good. Plus, it takes out all that janjat, mesh erosion, mesh infection, vaginal pain, thigh pain. All these things are taken out when you are doing a Burch. So I'm not trying to say that, okay, from tomorrow morning, everybody in India should start doing only Burch. No, that is not correct. Okay. But definitely, if you are treating a lot of non-Indian patients as well, then the preference for all these people is to not introduce a foreign body inside their system. Okay. And in those cases, you have to respect it. That's the first thing you have to do. You have to tell them that mesh is a foreign body. UK में banned है भाई. Okay, 1-2 more countries जहाँ पे कुछ ना कुछ तो banned है, बराबर. So the minute you put that thing ना कि वो country में banned है, automatically patient will be like, नहीं, then I want to go for something which is the other one. I don't want to do a procedure which one country has banned. Please try and understand this. Patients will not agree to this. Okay. So when you give them, still if they agree, you tell them, take it in writing. I have given you option for lab Burch. You are saying TOT. I will sit down again with you and I'll explain. I'll charge you also for explaining, but I'll sit down again and I'll explain, okay, what is the difference. Now you decide. Patient will tick mark on TOT. We do TOT. Okay, but see, another thing you must understand. We get so many referrals, no? Failed TOT, failed TVT. Burch attempted could not be completed. In that situation, I will only go for Burch because my comfort of anatomy is supreme. Like today's case. See, today's case, somebody put a TOT that got infected. They removed the TOT. Vagina, they sutured back. Everything they did. Now she's again with SUI. Now, how will I go and dissect through that vagina, you tell me? No. I will not attempt such heroics. I will do Burch. Beautiful repair. Patient is continent. She has passed urine in the hospital. She will go home tomorrow morning. Already she is thanking all the staff. Thank you. Abhi leak nahi ho raha hai. Okay. Morning we operated. Right now she is happy.
So role of Kelly stitch, someone is asking, Dr. Rajeshri.
No.
Okay. And
the question is, Jay, post hysterectomy, ward prolapse and cystocele with SUI.
Yeah. Put a mesh and do Burch. Put a mesh for the vault. Huh? What I meant to say is.
Okay. Any tips for laparoscopic surgery? We have another laparoscopic surgeon, Yogesh. Yogesh is there with us. Yogesh Surgupe. So welcome, Yogesh.
Oh, hi, Yogesh bhai. Good to see you, man. No, I mean, Yogesh bhai, probably when time permits, go through our live surgery on Facebook. I think it gives you the best tips, the exact way in which needle can be rotated, the exact orientation of the finger or dilator of the anterior vagina. I think it will really help you, is what I think.
Another question is, I think, prolapse with SUI treatment of choice.
So for the prolapse, you are supposed to put a mesh. There is nothing called treatment of choice. You are supposed to put a mesh, right? And for the SUI, you decide. If you think the SUI is based on hypermobility after correcting the prolapse, then you can do a Burch simultaneously. It's very, very easy to do. Very easy to do.
No, my question, sir, I would like to rephrase this. A patient has got, say, procedentia.
Yeah.
Along with that,
After you correct the proxidentia, she will have SUI.
okay, but till that time, how are we going to know? Once she comes after correction of procedentia, after doing the repair.
I think one very important thing which people should understand, 99% of the patients who are coming for prolapse examination, okay, or complaining of prolapse, for example, 500% they should be examined on an empty bladder as well as on a full bladder. The biggest mistake people do is that they tell their staff she's prolapse, ask her to pass bladder, ask her to pass urine and come, I want to examine. Very good, you examine that. You reposition the prolapse back, okay, fill up her bladder, let that prolapse come back, reposition it again, okay, and you ask her to cough. Never forget to do that in your prolapse examination. SUI is a part of prolapse. Just take it, because everything is a part of that fascia. So when you are examining the fascia, please examine it, because I've commonly seen people who have done vaginal hysterectomy, cystocele repair, 15 days later, patient is coughing urine out, kichuk, okay, and that time they did not examine. It was not patient's mistake, okay, it was not patient's mistake. It was examination's mistake. We forgot to do that small thing in our examination, and that caused the problem. Otherwise, we could have repaired both the things in same anesthesia, okay.
Yeah.
Yeah, I think.
Yeah, I think there's.
No, 1 hour is over.
Yeah, 1 hour is over. I think the questions are also apparently over. I don't see any questions.
But I think we can answer more questions in WhatsApp.
Yes.
Okay.
Yeah.
All prolapse do not. Can we combine Mayoward hysterectomy with Burch repair?
Can we combine what?
Mayoward routine vaginal hysterectomy with Burch Colposuspension.
Better to do DLH with Burch, no?
Okay.
Okay. I think that's about it. I think, Kiran sir. I think we can answer the rest on WhatsApp. It's 10:33.
Yeah.
Okay. So thank you so much, guys. I'll just stop the live. Give me 1 minute.